Clozapine, pros, cons, and alternatives. I think it's an important topic, and I think these are some important things to mention at the outset. First of all, this is going to be for a general audience. If I were speaking specifically to clinicians, I would get a lot more granular and I'd probably cover a lot greater detail, but I'm going to be talking on a bit higher plane and I'll have less grainy, nerdy specifics. If you want, I can certainly get to that area if you ask me questions about it later. Disclosures in terms of funding or potential financial conflicts of interest. My time and effort on this is funded by generosity of a charitable nonprofit known as PEGS Foundation, whose mission is simply to improve the lives of people affected by severe mental illness. PEGS is not influencing the content of this or pressuring me to move in any particular direction. I have no interest or ties to pharmaceutical or other commercial interests whatsoever. There is, unfortunately, it seems to be a relatively common belief that doctors get kickbacks from drug companies for recommending drugs or something. Not the case in general, and absolutely not the case with me. I'm talking about Clozapine simply because it is a useful option for many people in many circumstances. It's an underutilized and frequently misunderstood option, so I'm here to set the record straight in a way that I hope will be balanced as well as useful. I'll mention things that are so-called off-label, things that are not reviewed by the FDA. And I think it's important to mention that. I'm employed by Northeast Ohio Medical University, but the university does not vet what I speak about and may not necessarily agree. It may or may not, I don't know. Like I said, I'm speaking independently of my employer, so my views are my own and they're not involved with this. And I am a doctor, but I'm not your doctor. Think of me like a reporter more than a physician right now. I'm just bringing information out of the library to your hands. So that's as far as this goes. This is not to be construed as personalized advice. This is general information. Any treatment decisions should be enacted by a qualified medical provider who knows that person, who can examine that person, and who can consider all aspects of that person's unique circumstances before making any changes whatsoever. So I think all this probably is well understood, but I think it is useful to just say that explicitly at the outset. So thanks for your patience. Now, before moving on to the Clozapine topic per se, I think it will be helpful to just understand some basic background information about psychosis and about antipsychotic drugs. Psychosis, those of you who have heard me speak about this before, I will say again, psychosis is simply a symptom, a non-specific symptom that has many possible causes. Psychosis is a bit like fever, is something that is relatively easy to recognize, but once you see it, doesn't tell you anything other than there's something happening that deserves further investigation. Like fever, psychosis can have a lot of different possible causes. Psychosis can be a side effect of at least 100 different medicines or recreational drugs. Psychosis can be a symptom of, by my last count, about 50 different medical diseases. And psychosis is a symptom that can accompany about half dozen psychiatric conditions. So again, if somebody has psychosis, that's not a diagnosis, it's a symptom. And a person needs to go another step and figure out what is the cause or condition that best explains why a person is experiencing psychosis. Psychosis also has a lot of different potential chemical or physiological contributing factors. And this is where things, I think, get somewhat confusing and where the field of psychiatry gets confused upon itself, and I think where, to some extent, some disservices have been done to patients and families. We had a kind of giant breakthrough in the 1950s with the discovery of a drug called thorazine. And shortly after, we discovered that thorazine can help people with psychosis to have greatly reduced symptom severity. We figured out that thorazine does that by blocking receptors for dopamine. We took that finding that thorazine works to reduce psychosis symptoms by blocking dopamine receptors, and we coupled that with another set of observations, those observations being that drugs which activate dopamine receptors, for example, amphetamine, can produce psychosis. And we had two complementary sets of findings which suggested pretty strongly that psychosis can arise when the dopamine system is overactive. And that dopamine theory grabbed all the headlines and captivated all drug development literally for 50 years. And most everybody acts or acted like psychosis is a dopamine problem. And most cases of psychosis, at least half of them probably, do have a lot to do with making too much dopamine. So dopamine psychosis probably represents the majority of psychoses that occur. However, it's not the only neurochemical pathway to psychosis, and that's relevant to discussing clozapine. Because in addition to making and releasing too much dopamine, you can also experience psychosis by not having enough activity in neurochemical pathways that make and receive glutamate. Glutamate is a neurotransmitter that is used by half of the connections in the brain. So if you look at these nerve cell connections called synapses, half or more utilize glutamate. Numerically speaking, glutamate would be the number one neurotransmitter used in the brain. And if you impair the efficiency of glutamate signaling, psychosis results. People will have hallucinations and delusions. So glutamate psychosis is a thing. Drugs that impair glutamate signaling include ketamine or phencyclidine. Phencyclidine also goes by the abbreviation PCP, and it went by or goes by the slang name angel dust, notorious for causing a really severe psychosis, quite often associated with aggressive and violent behavior. Bottom line, drugs that impair glutamate signaling are pretty well known for causing psychosis. And then you also have another pathway to psychosis, which is overstimulating a subset of serotonin circuits in the brain, particularly serotonin circuits that utilize a serotonin receptor called the serotonin 2B receptor, or 2A, I'm sorry. I think 2A is the one, actually. LSD is a very strong activator of the serotonin 2A receptor. Psilocybin, the active ingredient in hallucinogenic mushrooms, is a very strong activator of serotonin 2A receptor. And interestingly, animal studies, rat studies, show that long-term administration of cannabis to adolescent rats causes those rats to have high sensitivity, upregulated serotonin 2A receptors. So that sets up an interesting theory that chronic cannabis use in adolescence may set up the brain to be more prone to psychosis because of sensitizing that serotonin 2A system. That's a speculation. But the overall point is that you can get psychosis through overstimulation in serotonin 2A receptor containing circuits. And then we know from people with autoimmune type diseases like lupus that having an inflammatory condition can produce psychosis as well. And all of these pathways to psychosis, people with lupus, people who are experiencing serotonin overdrive, people that are experiencing glutamate dysfunction, they can have psychosis that looks very much like schizophrenia, or that looks like the psychosis that develops when people are having mania. The main point that you can have psychosis from many different neurochemical pathways. And antipsychotic drugs, particularly the first generation drugs, are very good at blocking the dopamine receptors. And they don't really do anything for the other pathways of psychosis. So there, now we're getting at why a drug like Clozapine is, well, we're actually getting at why people don't respond to antipsychotic drugs. Because if you have a dopamine psychosis, then a dopamine drug works like really well. But if you have a glutamate psychosis or a serotonin psychosis, then a dopamine drug is kind of not relevant. And that's pretty simple to understand. But it's a point that is not apparently well taught in medical school or widely internalized and practiced. With second generation or atypical antipsychotic drugs, it becomes a little bit more confusing, because the second generation or atypical antipsychotic drugs, a lot of them build in some serotonin blocking properties. So the question then comes up, do the second generation drugs work better than the first generation drugs because they have this built-in serotonin blocking activity? And my answer to that is that they may a little bit, but it doesn't seem like most of the second generation drugs are that great at serotonin blocking to the point that they can be really superior to first generation drugs in terms of effectiveness. But whether or not their serotonin blocking is really going to solve serotonin psychosis cases still doesn't really solve the problem of people that suffer from glutamate psychosis or people that are suffering from inflammatory psychosis very well. And that's remains a problem. So this thing which my profession of psychiatry insists on calling treatment-resistant schizophrenia, a name which is, I think, unfortunately chosen. And I think, I'm sorry, since I brought it up, now I have to explain it. I think that calling it treatment-resistant schizophrenia is unfortunate because it communicates to everybody involved, patients, families, and doctors, what it suggests is this is like ordinary schizophrenia, just worse, because it's treatment non-responsive or treatment resistant. I think that's inaccurate, because what the data are telling us is that it looks like schizophrenia, but it's actually fundamentally different. It's not ordinary schizophrenia, just worse. It's a fundamentally different neurochemical disease that just has superficially similar symptoms. In other words, if it were ordinary schizophrenia, but worse, it would be like dopamine psychosis, but really bad dopamine psychosis. But it's not. It's probably serotonin psychosis, glutamate psychosis, inflammatory psychosis, or a medical disease like brain tumor, or some odd seizure disorder, or some other thing that is absolutely irrelevant to dopamine. So the point, again, I'm going to try to make this point again. What the field of psychiatry calls treatment-resistant schizophrenia, defined by not responding to ordinary antipsychotic drugs, is a very confusing and poorly chosen term, because although it has similar symptoms of psychosis, it is probably fundamentally different in what causes it, which very well explains why drugs like dopamine antagonists that work perfectly well for ordinary schizophrenia fail spectacularly again and again in this other form of illness. Drugs, doctors use them to like treat disease, obviously, but at the same time, drugs are actually telling us stories. Drugs are talking to us if we just know how to listen to them. When a drug works, or if a drug doesn't work, that is actually extremely useful information, because the response of an organism to the presence of a drug helps an investigator or a curious person to learn something about how that organism functions or the nature of the disease that's causing a symptom. So if a person with pneumonia gets penicillin and the pneumonia resolves, you do not need a fancy laboratory to tell you the cause of the pneumonia. We know that penicillin kills gram-positive bacteria. And if that person's pneumonia got better with penicillin, that pneumonia almost certainly was caused by gram-positive bacteria. If that person's pneumonia doesn't get better with penicillin, then that person's pneumonia was not caused by gram-positive bacteria. Or in the case of psychosis, if that person's psychosis doesn't respond to anti-dopamine drugs, that person's psychosis probably wasn't caused by making too much dopamine. But in the case of pneumonia, if they don't respond to penicillin, then they're not going to get better with 2 times or 3 times or 4 times the FDA recommended dose of penicillin. And I'm getting a little bit testy and my voice is rising because I see all the time in my practice people that are on 2 or 3 or 4 times the recommended dose, and they're still not getting better. And if the person is not getting better with penicillin, they're not going to get better with ampicillin, amoxicillin, carbamazepine, or piperacillin, or any acillin, because all these drugs are targeting the same thing. And similarly, the data show if a person's not gotten better with the first antipsychotic medication or the second antipsychotic medication, they probably haven't gotten better with the third one or the fourth one. And actually, Connolly and some others have looked at that empirically, scientifically, and they found success rates of 7% to 14%. The first drug failure and the second drug failure have pretty much shown you that this is not a dopamine responsive illness. And so, the third, fourth, and fifth try of the drug with the mechanism of action similar to the ones that already failed is probably already going to fail. So that's that. Howe and Kapoor. This paper is open access. You don't need a library subscription or anything. You can get it for free. It's 3 pages long. It's a little bit technical, but it's only 3 pages of technical. And they outline lots of different pieces of evidence, including some positron emission studies and biochemical evidence. But they several different lines of investigation show what I've been explaining to you, that not all schizophrenia is dopamine focused. There are a subset of people with symptoms that psychiatry would call schizophrenia, but biochemically is not related to making too much dopamine. So Howe and Kapoor very diplomatically and very neutrally call it type A and type B. Because I'm a little bit testy and I like to try to make some points memorably, would call one dopamine psychosis and the other dopamine irrelevant psychosis, just to make a point. So the bottom line is that you don't treat dopamine irrelevant illness by giving people dopamine blocking drugs. It doesn't seem to make a lot of sense, we'll say. And going back to some real data, like Connolly and colleagues say 7%, 14%. 14% was discovered with double the top end of the olanzapine recommended dose. So this was with 40 milligrams per day of olanzapine. This is really quite intriguing from a pharmacology point of view, because olanzapine is very chemically similar to clozapine, yet its success rate was far below clozapine. Clozapine is 50% success rate in cases of multiple antipsychotic failure. Clozapine is clearly way different in terms of what it's doing for people with psychosis. So moving into the pros, or why clozapine has a unique case for effectiveness. There's a statistic called effect size, and like the name implies, it's just a way to measure effectiveness of drugs so that you can fairly compare their effectiveness, even though they're not in head-to-head studies. It's kind of like comparing batters in baseball with batting averages. So you can guess the effectiveness of batters based upon sort of overall statistics, and that's what effect size does. Andrade came up with a meta-analysis showing various antipsychotic drugs, and clozapine was a standout. The thing about effect size statistic is that it's not a statistic with a big numerical range. So 0.9 is actually a big number. To put this in perspective, Prozac has an effect size of 0.6 for anxiety or depression. Most antidepressants, most psychotropic drugs actually have effect sizes of 0.4 to 0.6, which is on par with what you see for most of these antipsychotic drugs. 0.9 to 1 is the effect size you expect with amphetamine for ADHD. So for the clinicians, mental health clinicians in the group, that you'll know what that means. Amphetamine for ADHD is a highly reliable drug and disease combination, and clozapine for schizophrenia is that as well. So clozapine is a different league of effectiveness, and like nothing comes close. There's the closest competitor, olanzapine. Again, Lilly made it to be a chemical clone. They tried to copy it as best they could without violating the patent. And the closest you could get chemically to clozapine gets you to 0.6. And that, in the world of effect size, gets you from large to medium. So that's a big deal. Clozapine as well is the only drug in the entire world that has a government regulatory body approval for reducing the risk of suicide, which is a big deal, because in schizophrenia, half of people will attempt suicide and 1 in 10 will die from suicide. Clozapine actually has FDA approval for suicide reduction. And outside of FDA approvals, if you just look to broad scientific literature, there's only 2 drugs that have been shown to reduce suicide rates or risks. The other one is lithium. And so if you're interested in trying to reduce suicide risk, then clozapine is really a standout medication for that. In addition, clozapine reduces overall death rates amongst people with schizophrenia. We know this from a large study done in Finland. This slide is a bit complicated, but suffice it to say that the vertical line in each of these panels represents the odds of dying. Top panel from any cause, middle panel from suicide, bottom panel dying from heart disease. If you are to the left of the vertical line, this is good. This is lower than average. And if you're to the right of the line, that is increasing the risk above the comparison groups. So from all-cause mortality amongst people with schizophrenia on medication, only clozapine actually reduces all-cause mortality. So clozapine treatment in schizophrenia is reducing death rate compared to other drugs. So those are some benefits, and amongst the biggest of one is that it clearly works when other drugs fail. It works 50% of the time, whereas other drugs have 10% success rate. Nothing, unfortunately, comes for free or without risk, and clozapine absolutely comes with risks. and not a small number of them. There are workarounds for many of them, which I will now try to explain. These are sort of a compendium of common risks that my colleague Sarah Dugan here at Neomed compiled. And if I don't cover these in the following slides, certainly ask me and I can cover ones that aren't covered here. You can reduce sedation risk by starting at very, very, very low doses and favoring nighttime doses. Turns out that in many cases of sedation, just being active is enough to overcome it. And so that oftentimes works, and in my experience is frequently underutilized. And then it turns out, we talk about this a lot in my weekly sessions for clinicians. How to manage clozapine-associated sedation is a common topic. And because so-called treatment-resistant schizophrenia seems to be not a dopamine-mediated psychosis, then drugs that are dopamine-activating drugs like methylphenidate, aka Ritalin, or amphetamine, which typically worsen psychosis in dopamine-based schizophrenia, oftentimes are well tolerated in people with treatment-resistant schizophrenia. So these stimulant medications can oftentimes be used successfully to address clozapine-associated sedation without provoking psychosis in clinical practice. There are cardiovascular side effects with slowing down heart rate or feeling dizzy. And again, quite often, these can be mitigated by starting with a low dose and going very slowly. We can moderate their impact by sometimes just helping people to move more slowly from seated or laying positions. And if there are elevated heart rates, there are a couple of medication options for reducing heart rate if needed. I'm going to come to a second about the white blood cell suppression risk. Common misconception is that that is the most dangerous side effect of clozapine. The actual most dangerous side effect of clozapine is constipation. As Sarah has written, the most common cause of death associated with clozapine are complications from constipation. If constipation or bowel movement slowing happens, using stool softeners or laxatives is quite useful. I'm personally a big fan of using Miralax. I think it is, when necessary, is suitable for frequent or daily use. If one chooses to use fiber-based laxatives, it's important to give those with lots of water, because fiber-based laxatives, if they're not taken with copious amounts of water, can form kind of like bricks in the gut, and that would be a very bad thing. Docusate can be a stool softener. That's also quite common to be used. So anyway, there are many workarounds for constipation, and it's very important that that be monitored, because that is the one that is the most risky, it turns out. People can have sialuria, which is drooling. It seems to be because there is a impairment in the reflex to swallow. The workarounds for that are sugar-free gum or candy to just, it's a way to keep the sort of reminder to swallow. If it happens at night, then you can put a towel over the pillow. Some people will recommend using medications. There are certain medications you can take that do seem to work. I'm not a big fan of adding more medicines that you take swallowed by mouth, because those circulate throughout the whole body. I'm personally more inclined to use topical drugs. You can use some drops in the mouth or some spray under the tongue. Those in my practice have worked relatively well, and they're isolating the drug to just the site where it's needed. And there have been some people who use like basically Botox around the area of the salivary glands, and that can be helpful if needed. There can be some transient temperature elevation, which usually doesn't need treatment, but if needed, it can be treated with like aspirin or Tylenol. And blood draw, I'm going to talk about a couple of things with the blood draw. There is a requirement that there be at least weekly blood testing in the beginning. And then there's a whole schedule for blood testing. If somebody in the United States is on Clozapine, they'll have to have blood tested weekly for 6 months. And then assuming all the numbers are fine, then it moves to every other week for 6 months. And if all those numbers are fine, then it's once every 4 weeks indefinitely. So for people who don't like blood testing, that's a big deal. We can make it not as bothersome by using topical anesthetics. There's a thing called Emla cream or other sorts of derivatives. It's an anesthetic like lidocaine, where you smear it on the forearm, put a bandage over it, let it sit there for 45 minutes prior to the blood draw. Then the skin is anesthetized, so you don't feel pain. You just feel the pressure, but not pain. And you can make blood testing happen without pain, which is a good thing. If you talk with a laboratory in advance, you can do it. So you just do a finger stick, and then you will drop the blood drops into a small little tube, specially designed for finger stick blood drop collection. That can be an alternative to people who don't like big needles into the arm. If interested, talk to laboratory manager in advance. They make special devices and special tubes for that kind of thing. There is also a company called Athelas, which makes this really super cool device. If you're a clinician, you can get this in your office. And if you're a patient or a family, you can get it in your home. And this is also a single drop of blood. I think it goes onto a card. You put it in the machine, and the machine immediately gets you the blood count data, gets you a report, sends the report to the Clozapine Monitoring Center in one go. So that is a fabulous option, which really eliminates a whole lot of the hassle and almost all of the pain associated with blood draw. Because of the weekly blood draw, to monitor for a condition called neutropenia, which is a drop in the population of a certain type of white blood cell, what's the risk then? Well, it's not as big as many people imagine. We have now lots and lots of data because we've been drawing blood from lots of people for many, many years. The risk is 9 per 1,000. Or 0.9%. That's the risk of a significant drop of white cell count within the first year of treatment. That's not a severe drop. That is just a drop. And if you don't have a severe drop in the first year, then by the second year, your risk of having a significant drop drops to 9 per 10,000. So pretty low. If you wind up with a severe drop of white blood cell count, your risk of dying from that is 3%. So if you then take the combination of having a severe drop and dying from a severe drop, then you're looking at a risk of dying of 3 per 100,000. So the risk of death from loss of blood count or loss of white blood cell is 3 per 100,000. And I put in for comparison, risk of dying from suicide is 1 in 10. So now to be a little bit snarky or critical, by imposing this blood draw requirement and making it super difficult and logistically hard and everything else about Clozapine and creating all this, lots of people are not using Clozapine. And so to prevent 3 in 100,000 deaths from neutropenia, we are putting at risk 1 in 10 people from not using Clozapine. Iceland decided to just not do blood tests because ordinary clinical practice seemed to be adequate to catch these cases. Also, we've now learned that the risk of dropping white blood cells is not unique to Clozapine. Lots of second-generation antipsychotic drugs like Zyprexa and Seroquel and Invega come also with the risk of neutrophil drops, and it's not that far away from the risk from Clozapine either. So Again, I don't want to say it's not a zero risk, and I don't want to say that clozapine is a safe, wonderful medicine, because there's no such thing as a safe, wonderful medicine. All drugs have risks, to be sure, but I do want to put the white blood cell risk in perspective. It's not probably as big as many people imagine. And as well, mortality risk is 3 per 100,000 from white cell drop. Suicide risk is 1 in 10. So although clozapine has risks, untreated schizophrenia has risks as well. Other side effects, the other one is weight gain. That is a pretty big concern. Diet, exercise do work. I know people who take clozapine don't gain 1 pound of weight ever, because they just pay attention to what they eat. And actually, for many people, once their psychosis is in remission, and that can happen with great frequency with clozapine, then being able to be in control of your life and make good decisions becomes much easier. So when you get your life back, then a lot of things that seemed impossible become quite possible. So diet and exercise are effective. There is a medicine that is approved for diabetes called metformin. It's been in use in the world for 50 years. It has a pretty good safety record. Again, drugs are all risky. So when I say good, I mean relatively for a drug. But for people that have normal kidney function and normal liver function, it is relatively safe and has been pretty widely studied as for its ability to reduce weight gain from antipsychotic drugs. And it's really cheap. So so cheap that it can often be got for $4 for a month worth of medicine. So between low cost, large evidence base, and pretty large safety record, it seems like a pretty good first choice for pharmacological assistance to prevent clozapine-associated weight gain. There is a relatively new family of drugs that collectively go by the title GLP-1 agonist, liraglutide, branded under the name Victoza and Saxenda, or a drug that now I'm blanking on the generic name, but branded under the name Wegovy or Ozempic. These drugs look like they work. I mean, there are several studies of liraglutide for clozapine-associated weight gain. It seems to be actually very effective. So problem with these drugs are that they are quite costly, and insurance is quite stingy right now, but it's possible to negotiate, or at least to persuade. It may be possible to persuade insurers to cover that. There are several other medicines, more than this list indicates, but topiramate and memantine. Topiramate is a drug that psychiatrists are probably familiar with. It's an anticonvulsant drug, goes under the brand name Topamax. Memantine, I think psychiatrists are also familiar with it. It goes under the brand name Namenda, and it's approved for Alzheimer's disease. Both drugs have been shown to have some ability to promote weight loss and are reasonable options. So the main point is that weight gain is a very common side effect of clozapine, but it's also one that has many workarounds or many strategies for mitigation. Moving on, alternatives to clozapine. I promise this as well. And I said at the beginning of the talk, there's going to be off-label discussions. So if you look to what the FDA has approved for treatment-resistant schizophrenia, only clozapine exists. So none of these have any approval by the FDA or review by FDA. But here are some things that I think are worthwhile to consider in combination with clinicians. But lithium, there was in the 1990s, there were several papers that came out that were introducing the concept of a thing called lithium responsive schizophrenia. It seems that, or seemed that, it seemed then, and in my practice today, seems now, that some people with symptoms that best fit the description of schizophrenia do respond well to lithium. And data from the 90s are consistent with my clinical experience now, that subset of people with schizophrenia-like symptoms, if they respond to lithium, tend to respond pretty quickly to relatively low doses. So it might be, if one is looking for a way not to commit to clozapine, it might be worth a look at lithium to see if this person would be someone who responds to lithium. One of the authors of one of the lithium papers from the 90s, or from that era of papers, actually wrote in their discussion from their clinical study, they said, given what we know about lithium at this time and these findings, maybe we ought to consider the following: that everybody with schizophrenia symptoms should be given lithium first, because it seems that we would be able to figure out who's going to be a lithium responder kind of fast, and then we'll have an option. And if they don't respond to lithium, then we can go with the traditional option. That was a suggestion then, for what it's worth. Then Loxapine is an old drug, which, because of its age, is parked into the category of first generation drugs, but mechanism of action wise, it behaves very much like a second generation drug. It's a serotonin blocker and a dopamine receptor blocker, and it does this in ratios that resemble clozapine in many ways, especially when it's given at relatively low doses. There are case reports of Loxapine working where a person had been on clozapine and couldn't be on clozapine anymore. So that is not super well studied. Nothing in this area is, but Loxapine has been suggested as a possible alternative in case report literature. Then also, this is not a case report. This article is a small clinical study with, I think, around 50 individuals. It was written in 1989. In the description of patients that were studied, I think you could say that they probably would have been treatment-resistant schizophrenia, or certainly chronically ill individuals who hadn't had good response to several different attempts to treat them. And they gave them a drug called Acetazolamide, which is a unusual type of anticonvulsant drug that is designed to block an enzyme called carbonic anhydrase. And for interesting reasons, they decided also to give them thiamine. And the authors assert that they thought this combination was important, that acetazolamide by itself wouldn't have been as effective. I'm just telling you what the authors thought. I don't have an opinion personally, but they reported good results with this combination. And so I put this out because, as I said, the description of the patients that they enrolled sounded like they probably would have been called treatment-resistant schizophrenia, and they had notable results with this combination. Acetazolamide is still available as a generic drug. The modern day equivalent is zonisamide, which is sold under the brand name Zonegran. So there's that. And another thing to consider as an alternative to clozapine is that clozapine is being considered because a person has not responded to a couple of different antipsychotic drugs. So one should consider the presence of a medical illness. And in my experience, the examination for medical causes of psychosis is, the quality of the examination or the thoroughness of the examination is, shall we say, not consistent. And so I think at this point, when the person's clinical history has, declared this person to have not the usual pathway to chronic psychosis, then this, to my mind, screams that we should be rethinking the possibility that maybe they have like some kind of brain tumor or some kind of epilepsy or some kind of autoimmune disease or some kind of something. We should actually try to see what actually was the medical workup that has been done on this person prior to this moment. It's good to actually find the records and see what tests were done. And there have been cases where I've asked for those records, and the medical workup was complete metabolic panel, urinalysis, and blood count, and that was it. So quality varies, and I think it's certainly worthwhile to look for and see whether there's something there that was missed. And then 2 question marks after this one: anticonvulsant drugs. So lithium, as I pointed out, there is some data about lithium treating schizophrenia that hadn't responded to antipsychotic drugs. In my own practice, I've had a number of consultations from first episode clinics where the individual has not responded to 2 different antipsychotic drugs. And we've tried lithium before moving to clozapine, and it has worked. And where it's been successful has been where there's been like a family history of mood disorder or some subtle suggestion of a little bit of mood component to an illness. It wasn't really obvious at all that there was bipolar condition present, but for what it's worth, those were some clues that I had. Now, very speculative, lithium is useful for bipolar disorder. Some other anticonvulsant drugs are useful for bipolar disorder. So maybe, would it be possible that other anticonvulsant drugs could be useful for treatment-resistant schizophrenia? So 2 question marks, because I haven't seen any papers on that exactly, except for there are 3 case reports of people with persistent psychosis associated with cannabis use. And in these case reports, the person with persistent psychosis following cannabis had not gotten any results with antipsychotic drugs, and they got good results with either Depakote or with carbamazepine, which are 2 anticonvulsant drugs. So there's that. And I should put in one more thing I can write if I want to make a new slide. I could say, try a first generation drug. I know of cases in which a person has taken modern antipsychotic drugs, all the so-called second generation or atypical antipsychotic drugs, and they've gotten no good response. One guy that I know pleaded with his doctor, "Can I please be on Haldol?" His rationale was he recalled one time in the hospital, they gave him a Haldol, and he recalls having some clarity of thought or some freedom from symptoms. And this guy told me, my doctor said, "No, that's an awful drug." But the guy kept persisting that he should try it. And so the Haldol actually worked and cleared his symptoms. And he's actually been in remission for quite a long time. I know of more cases where first generation drugs worked, where second generation drugs failed. Related to this, there are, like in 2016, there was a review article published in which they identified 81 case reports of second generation antipsychotic drugs causing mania or worsening mania. So they might not work for some people, or they might worsen things. I think it is worthwhile to consider a first generation drug if it hasn't been tried, because they've worked in some cases. And so those would be my suggestions for alternatives. And again, there's not a lot of data to support that because there's not a lot of work in that area, but I did want to throw that out because I know there's great interest in alternatives to clozapine, and there are many cases in which clozapine is not an option for people, or where people have been not able to tolerate clozapine. So there's a need for considering those sorts of things. I do want to say one other thing about clozapine, and that is there can be great reluctance to clozapine on the part of patients or families, or on the part of clinicians as well. Some of the reluctance amongst clinicians that I've heard is that basically that's just a very side effect prone medicine. I know of a clinician who refused to prescribe clozapine because this clinician didn't want to give his patients any of those awful side effects. So I applaud the clinicians. You know, the heart was in the right place by not wanting to risk them giving diabetes or obesity or something. But on the other hand, by not giving them clozapine, this clinician was like consigning his patients to years of psychosis. So I don't know that that was a good deal for his patients. And other clinicians that I know just assume that so-and-so is not going to be compliant with blood draws, or is too erratic, or too whatever. So they just don't consider it. So there's that. So I will tell an anecdote for whatever it's worth. I had, at one point I was doing consultations. No, I was working in a state hospital actually. And so I'm going to use a made up name. The secretary for the hospital comes in and lets the chief nurse know that we'll call her Stephanie. Hey, guess who's coming? Stephanie's coming on her way. And so the eyes were rolling, and I was kind of new there. And I said, who is this person? And they said, oh, she's a frequent flyer. And I thought that's quite interesting. It's a way of deflecting responsibility for therapeutic failure away from us and toward the patient, So, but they were frustrated, of course, because Stephanie just keeps coming in and going out, and it doesn't get any better. Stephanie had been continuously ill for some 20 plus years, and she had a stack of charts, like it was huge. And so I started looking as much as I could. So she got ill when she was about 20 years old and never got better. And I go to see her when she shows up, and I asked her if she'd been on clozapine, and she shrieked and said, no, that's a medicine that requires blood testing, and she's afraid of needles, and so that's not a thing for her. So I told her about this stuff called Emla cream, and we could put it on her arms, and it would make it so that she wouldn't feel any pain. And that was really all it took. That was all it took. And she agreed. And then she did her blood draw, she got her medicine, and then she got better. And this is for the first time in her adult life, this woman was able to sit down with people in a discharge planning meeting and make a discharge plan that would work, that would not result in her becoming homeless, where she had been historically landing, where she had been sexually traumatized, victimized, and where she would wind up in jail. Her life for 20 years had been between jail and hospital and the street. And nobody had figured out a way to communicate with her to get her a drug that would work. So everybody had thought, we'll give her long-acting injectable medicine, and that didn't work, so they give her more of it and all this stuff. And the solution is not to give a person more of the medicine that doesn't work, or higher doses of the medicine that doesn't work. Yet now I'm getting pissed, because as I see it, the whole system is give more of the thing that didn't work. And there's this spectacular failure to think, it seems to me, or to figure out solutions to problems. I want to also complain that I understand that some people think that I'm some sort of genius person who solves that. I'm not at all a smart person. I'm a very simple person who thinks very basically. And to the extent I do anything special, it's just that I listen to people and I read stuff, so to the point that I can understand something. And then after that, solutions to problems become kind of simple to see. And if I can do it, anybody can do it, really. And so the solution to the whole cluster of the cluster blank that is healthcare is not to re-engineer more complexity. It is just to allow people to teach people that they need to listen and give them the time to do that. And then, that's how you solve stuff. But to come back to this story and why somebody should consider clozapine is because she didn't get better with her first antipsychotic medication. She didn't get better with her second. Assuming that they had her engaged in treatment, they would have identified her as a treatment non-responsive person within 8 months or less of her illness. And at that point, if they could engage her in clozapine treatment, she would have been recovered in less than 1 year of the onset of her psychosis. And she could have gone back to school and had a life like an ordinary life. But instead, she wound up with the, relatively typical, severely mentally ill person life. And so to those who think that so-and-so is too disordered or non-adherent or whatever, I would just urge you to at least figure out a way to give it a try, because in my experience, with great frequency, when successful, you wind up with a person who is able to engage in treatment in a meaningful way. And, insight can arise where there wasn't before. And interest in being treated can be where there wasn't before. And now, I'll get another bit scoldy. I am discouraged when a lot of times I hear my colleagues talk about so-and-so being treatment non-adherent as if they ought to be treatment adherent, when, if you think about it, when we give people a lot of side effects, but don't give them a chance to get a job or go to school or have friends, then actually a rational decision would be to not take medicine. So, people tend to take medicine when it gives them what they want, and people will tend to carry side effect burden when it gives them what they want. Most people who take clozapine actually carry significant side effect burden with them. Data support this as well, but most people who take clozapine say in surveys, and also tell me in person, that they would rather stay with clozapine despite the side effect, because they get what they want, which is to enjoy reading, enjoy playing the violin. They get the life that they wanted to have. And so they're able to tolerate the burden of side effect because it gives them the things that they're after. So just to those who are skeptical about it, that's been my experience with it. And to be clear and be balanced, not everybody has success with clozapine, and it does have risks. So I don't want to be the guy who says it's magic, but there are ways to manage risk. And for those who are hesitant, I hope that there has been some reason to be somewhat optimistic about the ability to give it a try.